Hello, this is Dr. Hamel, and the case of today is 84 years old, presented with acute MI, hypotensive and congestive heart failure. You see the culprit here is the LCX, which is dominant circ, completely occluded, proximal, and you have also the LID has tight lesion there, 99%. And here is different view in the crane view. You see the LID has a couple lesions in the mid segment and the distal. Of course, the circ is completely occluded. Here is starting intervention as usual with XB35. You have good support. There is 2O run through wire and 2O balloon. I always support the wire with a short balloon, and then here negotiating through the stenotic occluded cap, and advance the wire distal, which is a left PDA, and then here you do inflations, move the or drag the balloon, push the clots if there is any, and then after inflation you see the vessel. We have very it's a large system in the OM, which is feeding the apex. Tight lesion there, there is moderate lesion there, and this branch is feeding the large PL or PDA branch. Right away advance another wire toward the major OM and do now inflation with higher or bigger balloon, which is 275. And here the flow is better, so here we're gonna fix this lesion here, and then another lesion in the ossia, and at the same time we're gonna fix the circ toward that large PDA up to here. Starting here with 2.5 stent. This is 2.5 drug-eluting stent, and then 2.75 stent up to the ossia at high pressure, flaring the ossia here, crushing with NC balloon, 7 fluoro as usual. You see where we're gonna place the stent. From here up to there we're gonna put 3038, and here is the 3038 stent at high pressure after we pull the wire out of the OM. Here the angiogram after 7 fluoro. I see the flow still sluggish, so I did pronto LP thrombectomy before advancing the other wire. You can advance the catheter with 2 wires in 6 French sheath or 6 French guide, so you have to do it with 1 wire. Did the thrombectomy, then we're gonna wire the OM. Now we're gonna wire the OM. Always start with buckling the wire so you avoid going through the struts here, and then correct the buckle and go through the struts as here. And here dilating each one separately at higher pressure and C, and then nominal pressure in the kissing balloon. And here is the final for the circ. You have very nice flow in those 2 big huge circ system. So here I'm gonna stop here and send the patient upstairs for CHF pulmonary edema treatment, and then bring him next day to fix the LID. Here is next day after, of course, the intubation and the here femoral axis, and then the stent is still widely patent, and then here's the XB guide, and here's wire in the diagonal. We have 2 lesions as we mentioned, distal and mid segment, 2O balloon for the lesions, and here is 2.5 stent for distal and 3O stent for the mid segment. And here is the angiogram. You see there is Still have a waste there, so post dilated at high pressure, and then here is the final results. We have nice results for the LD. Um, here is different view for both the LD and the circ system. All right, thank you for watching.